presentation. The title is Camizestrant, a next-generation oral SERD versus fulvestrant in post-menopausal women with advanced ER-positive HER2-negative breast cancer. Results of the randomized multi-dose phase 2 SERENA-2 trial will be presented by Dr. Mafalda Oliveira.
Thank you, Carlos. Thank you, everyone, for the opportunity for being here to present in firsthand the results of the SERENA-2 trial. So these are my disclosures. Camizestrant is an oral selective ER degrader and antagonist that has been tested in a phase 1 study across a range of doses and has shown a very good profile of inhibition of the ER. And we designed SERENA-2 to assess different doses of camizestrant in comparison with the standard of care fulvestrant in patients progressing to prior endocrine therapy. So in SERENA-2, 240 patients postmenopausal with ER-positive HER2-negative advanced breast cancer candidates to receive fulvestrant monotherapy in the advanced setting were included. Additional key inclusion-exclusion criteria included recurrence or progression on at least one line of endocrine therapy, no prior fulvestrant or oral SERDs for advanced disease, and no more than one line of endocrine therapy or chemotherapy in the advanced setting, as long as the presence of measurable or non-measurable disease. So these patients were stratified according to treatment with prior CDK4/6 inhibitors and with the presence of lung or liver metastasis, and were randomized 1:1 to receive 3 different doses of camizestrant, 75 milligram, 150 milligrams, 300 milligrams, and or the standard of care fulvestrant. The arm of camizestrant 300 milligrams was discontinued after 20 patients were included because of a strategic reason in the absence of toxicity concerns, and I will show those data later on. The primary endpoint for SERENA-2 was PFS, according to investigator assessment. Secondary endpoints were clinical benefit rate at 24 weeks, overall response rate, overall survival, and of course, safety. And we also have a number of translational endpoints, including serial CTC analysis and measurement of ctDNA, including ESR1 mutations. So, as I said, 240 patients were included in this trial. Median age of the patients were 60. Most of the patients had ECOG 0, and all of the patients, as per inclusion criteria, had ER-positive disease. We planned in advance to include 50% of patients with prior treatment with the CDK4/6 inhibitors, and that's exactly what you can see here. Also, the other stratification factor, as you remember, was the presence of lung or liver metastases, and this was present in 58% of the patients. 37% of the patients had a detectable ESR1 mutation at baseline. 20% of patients had received chemotherapy in advanced setting, and all of the patients had received and progressed to prior endocrine therapy. In the adjuvant setting, this number was 67%, and in the advanced setting, 70% of the patients had progressed to endocrine therapy in this setting. So these are the primary results of the SERENA-2 trial. In the overall population, camizestrant produces a statistically significant and clinically meaningful improvement in PFS for both 75 milligrams and 150 milligrams over fulvestrant. It is important to note that the trial was powered to detect differences between the 2 camizestrant doses and fulvestrant, so camizestrant 75 on fulvestrant and camizestrant 150 on fulvestrant, but not between camizestrant 75 and 150. As you can see here, camizestrant 75 in comparison with fulvestrant reduced the risk of progression or death in 42%, and at a dose of 150, this reduction was of 33%. The median PFS for the 3 arms were 7.2 months for camizestrant 75, 7.7 months for Camizestrant 150, and 3.7 months for fulvestrant. We also conducted a blinded central review of PFS as a sensitivity analysis, and it also showed a statistically significant benefit in PFS at both doses of Camizestrant over fulvestrant, which was consistent with investigator assessment. Now we will go some of the important subgroups because these are subgroups of unmet clinical need, and to see the activity of Camizestrant over the standard of care fulvestrant. First, the group of patients that had received prior CDK4/6 inhibitors. So in these patients, prior treated with CDK4/6 inhibitors and endocrine therapy, and also in those patients with lung or liver metastases, Camizestrant at both doses produces a clinically meaningful improvement in PFS over fulvestrant. You can see the hazard ratios there, a reduction in 51% in the risk of progression or death with Camizestrant 75, and a reduction of 32% with Camizestrant 150 in patients that had received prior CDK4/6 inhibitors. And similar hazard ratios also for the subgroup of patients with lung or liver metastases. There was also activity of Camizestrant over fulvestrant in the group of patients with no prior CDK4/6 inhibitors, although the activity in the group of patients with no lung or liver metastasis was less clear from this study. Another two important groups are the group of patients with ESR1 mutations, and you can see that graph on the left. So in the subpopulation of patients with detectable ESR1 mutations at baseline, Camizestrant at both doses produces a clinically meaningful improvement in PFS over fulvestrant. Reduction of progression or death here was 67% for Camizestrant 75 and 45% for Camizestrant 150, with median PFS values of 6.3, 9.2 compared to 2.2 months with fulvestrant. Also, in patients with evidence of ER-driven disease, and this definition is according to the ABC5 definition of secondary endocrine resistance, just shifting to 12 months the limit for patients receiving prior CDK4/6 inhibitors. And here, in these patients with ER-driven disease, again, a very consistent benefit of Camizestrant at both doses compared to standard of care fulvestrant. We also looked at changes in the ESR1 mutation ctDNA variant allele frequency in the three treatment arms. And as you can see depicted here, treatment with Camizestrant 75 and 150 milligrams reduced the level of ESR1 mutation ctDNA to undetectable or near undetectable levels by cycle 2 day 1 and maintained this to cycle 7 day 1. And fulvestrant also reduced the level of ESR1 mutation, but not to the same extent as Camizestrant. Regarding objective response rates and clinical benefit rate at 24 weeks, Camizestrant at both doses increases these two efficacy parameters over fulvestrant. And of note, the clinical benefit rate at 6 months in the Camizestrant arms is 50%, meaning that half of the patients included were still deriving benefit from these treatments at the 6 months time point. Regarding safety, treatment-related adverse events of grade 3 or higher and treatment-related adverse events leading to discontinuation were infrequent across treatment arms, as you can see in the table. And also infrequent were the treatment-related adverse events leading to dose interruptions and were of very short duration. So median duration of drug interruption was 1 week, 7 days. And all Camizestrant doses are well tolerated. What are the most common adverse events with this drug? So you can see here all treatment-emergent adverse events independently of causality, and the most frequent adverse events with Camizestrant are photopsia, visual flashes, sinus bradycardia, fatigue, anemia, asthenia, and arthralgia. But I would like to call your attention to this important column that is events of grade 3 or higher. And as you can see, the proportion of grade 3 or higher events with Camizestrant is extremely low. So in summary, SERENA-2 met its primary objective. Camizestrant at both 75 and 150 milligram doses improves PFS over fulvestrant in post-menopausal women with ER-positive HER2-negative advanced breast cancer. Camizestrant delivers statistically significant and clinically meaningful PFS benefit at both 75 and 150 doses over fulvestrant in the overall population, and a clinically meaningful PFS benefit was observed across the pre-specified subgroups of unmet medical need, like patients progressing after CDK4/6 inhibitors, patients with lung or liver metastases, patients where there is an emergence of ESR1 detected, and also those patients with evidence of ER-driven disease. Both camizestrant doses are well tolerated, with infrequent grade 3 or higher treatment-related adverse events, dose reductions, and discontinuations. So in conclusion, the results of SERENA-2 support the further development of camizestrant in ER-positive breast cancer. And now, currently, two phase 3 studies of camizestrant in advanced breast cancer, SERENA-4 and SERENA-6, are ongoing. So with that, I'd like to thank the patients and all their families for participating in this trial, all the investigators and site staff for their contribution, AstraZeneca for supporting the study, and there in the QR you can find a link to a plain language summary with the SERENA-2 results. Thank you so much for your attention.
Thank you very much. So you can stay there for questions. Yeah. So moving forward, what's going to be the dose?
Yes. So the dose that was chosen to SERENA-4 and SERENA-6 is the dose of 75 milligrams. I think that SERENA-2 results show consistently that camizestrant, that these both doses is superior to the standard of care. But again, it was not designed to compare both doses.
Thank you. Question?
Yeah, Neil Osterwald with MD Edge Hematology Oncology. So I noticed for your primary endpoint, for the 150 dose, you've got a PFS of, median PFS of 7.7 months, and then for the 75 dose, 7.3 months. Hazard ratio for the 150 dose is higher. I know you're not comparing the two, but why? What were the adjustments in the hazard
Yes, that's
ratio?
an excellent question. And the question here is that the hazard ratios are adjusted for the prior certification factors. So prior CDK4/6 inhibitors and presence of liver or lung metastasis. The Kaplan-Meier curves and the medians are not adjusted for these factors. And this is why it seems that it goes otherwise. But the adjusted hazard ratio gives us a more realistic and more precise measure of the magnitude of benefits.
And Dr. Ardiarga, and maybe the other columnists, would you mind commenting on your impression? You know, I know it's an early but impression of this agent versus fulvestrant.
Versus fulvestrant?
Yeah.
Well, there's a clear suggestion that this might be better. Also, looking at the effect on the ESR1 mutations, I think also they appear to be better at reducing that titer in the plasma of the ESR1 mutations. And that is based on basic science that supports that, again, that these mutations may respond better to these new SERDs. But obviously, this is a small study, but the direction seems to be consistent with, you know, what the science has told us.
Mm-hmm. Great, thank you.
Yeah, next question.
Caroline Helwig, Gasco Post. So what are the differences between camizestrant and elacestrant, which is we're more familiar with, it's further along? They're both SERDs, but can you tell us if there's something that distinguishes yours?
Yeah, so they both have the same mechanism of action. They are SERDs, they antagonize the ER receptor, and they degrade the ER receptor, so they belong to the same class. Unlikely fulvestrant, that is an intramuscular injection. These are also pills. So I think that now we have two very interesting pieces of evidence that this new class of drugs may be superior to the current standard of care.
Okay. Do you want to comment on that, Dr.?
No, I was just asking her about the photopsia and
Okay.
whether that was a surprise and whether there's an explanation for it.
Yeah, that's a very important question because this is an adverse event that we started to see in the phase 1 trial. And it seems dependent of the dose. So at higher doses, it seems to occur more frequently. But it is extremely important to note that these are grade 1 events. So these light flashes that patients experience more in the morning or at evening, but do not interfere with their daily practice activities. So they can keep driving and reading and watch TV, etc. So Regarding the mechanism, for now, it is unclear. So in all the SERENA studies, there is included a thorough ophthalmologic evaluation for all these patients, and we have found no structural alterations in the eye or other structural things that could explain the photopsia.
Yeah.
So this is currently ongoing investigation.
So that's one differentiating factor of these SERDs. The toxicity appears to be a little bit different.
Toxicities are different.
Yeah, albeit mild, fortunately. So it's like Pepsi-Cola and Coca-Cola, kind of.
Yeah. So photopsia is not really seen with the elacestrant that we know of?
No.
Not that I'm aware. Okay. Thank you.
We have two questions from the webcast.
Okay, let's go.
The first is from Jean-Claude Lemaire for MediaScoop. He asks if you could please clarify why the 300 milligram dose was discontinued.
Yes, excellent question. Thank you. So when we looked at data from the SERENA-1 trial, where we escalated dose until 450 milligrams, we saw that there was a relatively flat exposure efficacy relationship from 75 to 300 milligram. So by doing that, AstraZeneca decided to go with 75 milligrams for the SERENA-4 and SERENA-6 trial, and 300 milligrams was actually 4 times the dose that was selected for the phase 3 trials. And for that reason, the arm was discontinued. It is important to note that patients that were already randomized to that arm were allowed to continue treatment at 300 milligrams, or they could dose reduce to 150 or 75 according to protocol guidelines. But there was no, there were no toxicity issues about the 300 dose that made us discontinue that arm.
What is the second question?
The second question is from Lynn Brook with Oncology Data Advisor. She says, with these results, are there any plans in the works for clinical trials to further measure efficacy and safety of other potential oral SERDs?
Well, for Camizestrant, there are 2 ongoing trials right now. SERENA-4, testing Camizestrant in combination with palbociclib versus the standard of care AI plus palbociclib in first line, and the SERENA-6 study that is addressing the emergence of ESR1 mutations during the first line treatment. Okay. And now these are the current trials that are ongoing.
Yeah, thank you. Thank you. Thank you. The next presentation is